Good afternoon, everyone. Thank you for coming. I'm going to kick off by talking a little bit about what Philips is. Some of you will know us for different reasons, so I'll just talk through and give you a bit of an introduction to Philips. And then I'm going to pass on to my colleagues, and you'll hear a little bit about what we've done in Liverpool and also what we've done elsewhere. So, for those of you that don't know, Philips actually sold off the TV business 5 years ago. And then in February this year, we separated out our lighting business. So we're now absolutely 100% focused on being a health tech company. And what that means is that we're able to join up our heritage in consumer and our heritage in healthcare and really bring those together to bring insights across the whole healthcare continuum. So what you can see on this slide is on the left-hand side, we're really supporting various innovations in the home environment. So we're known as leaders in oral healthcare. If you go to our stand, you'll be able to enjoy the fruits of our juices. Then we've got a very established business within the hospital environment. We're number one for patient monitoring. We're known for our diagnostic imaging. And then out in the home care environment, this is about how we can support patients in various different programs outside of the hospital setting. And I'll come on to talk a little bit more about that. So we have this mission of improving people's lives through meaningful innovation. And you've already seen how we do that across different care settings, from the home into the hospital and then out into the community setting. But we also do that across people. So particularly within population health management, what you find is there's a huge diverse set of stakeholders that need to be involved. And that's both on the patient side and on the clinical delivery team. So we make sure that we involve those all the way across in every single care setting that we touch. If you were at the conference yesterday, you might have caught the talk from Jeroen Tas, who is our Chief Executive of the Health Informatics business, and he presented what we're doing in terms of bringing data together to allow you to drive these meaningful innovations in a very targeted fashion at specific cohorts of the population. We also do this across time. So I think the first interaction we have with someone is as they're born. So we've got Philips Avent baby products, and then our solutions go all the way through to end of life, and we've got a whole load of services that we deliver to the frail and elderly. What we've noticed in the NHS specifically is a number of shifts in the way that care is delivered, and so we've highlighted three here. Consumers are increasingly engaging in their own health, and we need to be able to accommodate that, and we need to be able to support them. We're also seeing a shift towards value-based healthcare, so moving away from fee-for-service towards a model where we commission based upon outcomes. And then finally, we're seeing this shift towards lower-cost settings. The structure that we've got at the moment is unsustainable, and we need to move towards a model where we're able to support patients in a different way. So how do we address those different shifts? Well, we see two major trends. The first of these, industrialization of care, is a slightly inhuman term in itself. But when you combine it with the other major trend that we see, personalization of care, it takes on quite a different meaning. And if you think to some of the household items that you use on a daily basis, take your car, for instance, the mobile phone in your pocket, these are all products which are delivered off a production line with a very efficient manufacturing process. But they're customized towards you so that you feel some kind of ownership of those devices and of those solutions in your life. And I think we need to take the same approach towards healthcare. We need to be delivering efficient healthcare at scale, but we need to be doing it in such a way that we're personalizing it for the individual and allowing for patient choice. But it's not easy. So we've been working at this for quite some time in population health management, and we know that you're faced with a whole load of questions in dealing with this. So I think it's about learning as you go, and we've been on a bit of a journey in Philips towards population health management over some time. We made our first acquisition in this area some 10 years ago, and we continue to develop and learn as we go now. But what we think is really important is that you address all of these four different factors. So in the first instance, the reason we're in this business is to drive better outcomes for patients. So that's the first and foremost consideration. I think once you can evidence that you can deliver better outcomes, and we can do that now, then you need to give some consideration to how you deliver an efficient workflow that supports greater caseloads and supports the best use of the finite resources that we have within the NHS. Coupled with that is the financial savings. So some of that is around the shift towards lower cost settings, so taking people out of the hospitals, supporting in the best place for their care, and doing so in a cost efficient manner. And some of it is around reducing healthcare utilisation, so avoiding admissions. What we think drives all of these is patient engagement. And so we make it core to the services that we provide, making sure that we have a means of enabling patients to better self-manage. They need to be activated to do so. So that comes on to what our approach is, I guess, and it really starts with an analytics-driven approach. So we made an acquisition earlier this year of a company called Wellcentive, and that really cemented our commitment to making sure that what we do in this environment is all analytics-driven. So we want to be using information that we can glean about the population to make sure that we're targeting the innovations at the right cohorts of population. Once you've identified the right cohorts and you know where the demand is being placed upon the system, it's then about making sure that you deliver the right solutions to those patients. And you know, the technology is one part of that, but it's really not the most important part. The crucial part here is really about making sure that you've got the processes and workflows in place to make sure that healthcare providers can be as efficient as possible in supporting their population. And we think one way that we can make sure that we're aligned with that process is through contracting and an outcome-based commissioning approach. So where we sign up to say we're prepared to take on some risk to deliver these outcomes, then we make sure that we're both aligned in terms of achieving our primary goal, which is improving those patient outcomes. And finally, as I alluded to earlier, you know, you've got to make sure that you do the stakeholder engagement right up front and all the way through these services. They're very complex, they're not easy nuts to crack, and so you need to make sure that you engage the whole healthcare system in delivering this. And I think that's probably where we differ from some of the other competitors out there, is that we know that we can't do this all ourselves. You know, we're very open to working with third parties, and we see Philips' role in that as a service integrator. The other key partnership is obviously with the local healthcare economies. You know, we've got to make sure that we're aligned on our vision and our strategy. We've also got to make sure that we put the right program management in place to do so. And so on that note, I'd like to invite my colleague, Dr. Maurice Smith, to the stand, and he's going to talk a little bit about how we've partnered to deliver a fantastic service to Liverpool.
Good. Right, thank you very much, Rupert. That's great. It's very good to be here. So I'm going to tell you just a little bit about Liverpool, about what's going on, some of our particular challenges, where we started from. We're going to talk a little bit about what we did, how we got going, what we learnt, and then something about our results. So if we go through things. So Liverpool CCG. So we're responsible for 450,000 patients, a budget now of £860 million. So effectively what I would call a shed load of money. We have got the responsibility of spending. Nevertheless, we are in a cost-restrained system, and I think you'll find that pretty much all CCGs will tell you that their millions and millions are all committed now, and they've got little wriggle room to make a difference. So what have we got to do? I'm not going to bore you with all the details of CCGs. I'm sure this audience knows all about them. So in the interest of time, just looking ahead. So we want to have a health and social care system that's person-centred, provides people with the best care to stay well. Now, there's nothing new here, is there? Everybody would sign up to that. But we've got some really big ambitions. We want to avoid avoidable mortality. We want to improve quality of life. We want hospitals to be good, but we want our community-based experience to be in the top 5 across the whole country. We've got some design principles that really underpin how we've looked at designing our transformational programs. I'm not going to read them all out individually, but I'm going to draw your attention to a couple. We want to be proactive. It's really important. We want to make the best use of digital technology, and that was right at the start of our 5-year journey. So we've effectively put those principles into our 5 transformation programs. So we're looking at community care, hospital care, urgent care, my own Living Well program, which is now very dear to my heart, and digital care and innovation, where I still remain the lead for the assisted living technology side of things. And our ambition is to be one of the 10 most digitally advanced health and social care economies in Europe. But why? We want to enable people to use digital technologies to manage their own care. And that's really crucial, to really leverage digital technologies, not just for the sake of saying you've got a bit of kit that you can use and that's great. We want to make a difference. So in terms of our digital program, we've got 4 main areas. We've got iLinks, which is all about connectivity, about how systems work, about how they talk to each other, about how we share information. We've got literally My Program, or MI for more independent, which is the assisted living technology program through which we've got to telehealth at scale. And looking ahead, we're working on patient health record, not again as an end in itself, but we're looking at developing a PHR platform so that third-party developers can actually work up their own apps, their own developments, to present information to people in ways that are useful to them. And I'm sure you'll have heard about that at other presentations. And we also want to make best use of predictive analytics, so-called big data conversation. That's beyond the scope of today's discussion, so I'm going to move rapidly on. So telehealth, what did we have? We had a 3-year program that we were funded for from 2012 onwards, and our ask effectively was to implement telehealth at scale. We were targeted. We said, right, you've got to get 1,600 patients onto this stuff, make it happen. All that we had to go on was Whole System Demonstrator. And although Whole System Demonstrator was written up as a great success initially, I think it's pretty fair to say that by the time it had been dissected by the medical press, it was a great deal of skepticism about it in actual fact. And people were less convinced, from my perspective, than they had been before about the whole value. So we were starting again. And we were starting from a very practical point of view, not an RCT. And I've stolen my friend's line here, which is RCTs are sometimes held as the only way that we can prove that things work. But it's not the best way for everything. You don't want to test parachutes by using an RCT. It could all get very messy. So we've got to acknowledge that there are different ways of doing things. We talked about stakeholders. At the beginning, the technology wasn't the most important thing. The most important thing was the human factors. What do people want? What do they need? What will they respond to? And we had to be prepared to fail, and we did a few times. So, stakeholder management. This is your average British person. Liverpudlians don't look like that. But the point is that you have to understand your target audience. So, who are the stakeholders? Well, we have people like this lady who's really into telehealth. And by the way, age is not an exclusion. We have this idea that's put about that the elderly people really struggle with this and they're going to have problems. They're not. I had on my own practice list a 90-year-old bloke who I went to visit who took great delight in showing me his system, how it all worked, and how much more confident he was. And that's just a one-off anecdote, but it's so true. On the other hand, not everybody wants technology. Not everybody is up for this. And I think one of the dangers is deciding that this is a one-size-fits-all. We will put it onto somebody and great things will happen. And what we've learned is that just isn't true. We need to find people who want to engage in this way. We've got our clinical colleagues, and there are some people who are up for it straight away. They're on board, they want to be there, they want to be the early adopters. So we take them with us. We've got the people who are a bit ambivalent. They're not so sure. Now, I think that's where we've got our great wins, to be honest, because if we put our effort there, along with the people who want to go forward, we will have the majority of our clinical workforce. We've all met this bloke. If you put your energy here first, you'll take a lot longer to get where you want to go because he doesn't want to play. Don't waste your energy there to begin with. Put your energy here. He will come round quite quickly to seeing this is a really good thing. We spent a lot of time understanding our practice population, the people of Liverpool. So our insight team in Liverpool has done a lot of really good work. I said this at one of the meetings yesterday, that one of the key points that we've learned, which is always shocking to an audience like this, where everybody's, patient-centered and patients are important and, we believe that health is the most important thing and that's what we're all about. Actually, most of the population, certainly Liverpool, health is not top of their list of things that they're interested in. So we want to be careful about making that mistake of putting something out there and say it's going to make health better, and then be surprised when people say, yeah, and? You know, people want to be warm, they want to be safe, they want to be comfortable. This is the classic hierarchy of needs triangle, but it is so important. Once people are comfortable, they do understand the difference and the benefits that health and well-being gives, but they need to be in a good place, and they need to be ready to adopt technology in order to move on. So I think that's worth looking at in whichever group of people you're looking to implement. So we got really serious about clinical engagement. So I was very lucky. I was sort of asked to head up and chair our program board. So I'm a GP. One GP does not make clinical engagement. Certainly not across 450,000 patients. It's absolutely impossible. So one of the things that I was keen to do was to have a clinical reference group, get more GPs, spread the word, share some of the responsibility, and our practice nurses and our clinical nurse colleagues to be part of the clinical reference group, to sense guest stuff, make sure we're not going up any blind alleys, give a bit more challenge. My view is not the only view, and that's certainly true in my house, but we'll talk about that later. So we learned some valuable lessons. The first thing that we tried to do was go down the route of recruitment via specialist nurses, heart failure nurses, etc., etc. And what we discovered was, whilst our nursing colleagues were very well meant, actually it was hard work. They didn't have the throughput, the volume of patients to recruit at scale, and each individual one took quite some convincing. So it became painfully slow. And we thought, what can we do? How can we recruit? You know, we've heard lots of areas struggle to get to scale. So we had a bit of an epiphany, actually, which is, where are the patients? And strangely, they are in general practice, and they're all on practice-based lists, and anybody who works in primary care has a huge list of virtually everybody in the city by the time you add them all up. So we went to the practices to start to recruit. But we spent 12 to 18 months going round our GPs through the various networks to have this conversation, to say, is this something you'd be interested in? Would you like to be involved? So by the time that we were actually ready to launch, then we had an interested group of practices. But sadly, the GPs, they don't want more work. They're plenty busy enough, thank you very much. So we need to make life easy for them. I always say at these type of meetings, it depends. If you're an altruist, then it's what's in it for my patient and what's in it for me. And if you're not an altruist, it's what's in it for me and what's in it for my patient. But either way, we need to make the case both sides. So what did we do? So we have developed in Liverpool a hub-based supported care system. So I'll just quickly flick the whole slide up so you can see it all. So we've got a central hub which is capable of monitoring about anywhere between 500 and 700 patients at any given time. It's staffed by clinical nurses. There's service support from Philips. We're going practice by practice in terms of what we call onboarding patients, and we're onboarding about 40 to 50 patients a week currently, and cumulatively over 3,200 patients. So we think that cumulatively we're still the biggest deployment of telehealth in England, possibly in Europe. There are other areas catching up, so good luck to them. But we're still leading the way, and we're still learning. So across the bottom here is our process map. I think every presentation has to have one slide that nobody can possibly read, and this is mine, so don't try and read it. But it basically describes a process of practice-based case finding, which we'll go into in a little bit more detail. So what did we do? We looked for people with heart failure, diabetes or COPD, those being the clinical areas that we thought that we knew that it might be beneficial for. So that was the construct. And I'm not going to read it all detail by detail, but effectively we went to each practice that was keen to be involved, and we said, find us those patients. You guys have a look at your list, see if there's anyone who you think actually you definitely don't want. You know, is it Mrs. Williams? Is it Mrs. Jones? You know, do you know about them? Everybody else, we, the telehealth team, will phone up. Are you interested? If yes, you'll get a visit. If no, fine. You know, we're not going to keep... We don't want to, in the same way that we don't want to sort of try and persuade Mr. Angry T to be involved, we also don't want to try and persuade people who don't want to be engaged in this. So we were able to quickly get a list of about 5,000 patients across the city who we're able to make contact with. And Case will go through some of the detail of the results later in a bit more detail. So I'm just going to show a little video now just about a patient story, just so you can see the system and how it might work.
Well, I've got several conditions. I've got angina, an inoperable brain tumour. I've got COPD and neuropathy. Some days I can cope very well, other days I can just sit down and do nothing. I can only take so many painkillers and I can't climb the stairs, I've got a lift. But it's better, I'd sooner be here than be somewhere else. I've been using telehealth now for months. It's been a great support to me and it's gave me a lot more confidence with myself because I know there's somebody there. If I have got a problem, I can ring them and ask them and they will tell me what to do. That is telehealth and it's a wonderful thing.
Telehealth transformed both our lives because, and especially Lil, because the fact that you've got somebody on the end of the line and that's made a massive improvement to her. You know, to give her peace of mind and everything you can think about. For me, it was a constant worry about her because once she wasn't well, she'd go into depression. The fact is now, she's not worried. She knows at the end of that phone is somebody who can help her. So it gives me peace of mind as well, you know.
At first, I did get a bit mucked up and bothered and things, and then all of a sudden it just clicked. Now I can do it within, 5-6 minutes, do all my blood pressure and my oxygen levels. Telehealth has stopped me going back in hospital because it's told me things that I didn't know I had, and I've been able to go and get it sorted out. I had a fast heart rate of 142. Now they were on the phone right away. They didn't wait, they just phoned me. So I went to have an ECG and I found out when I went back to the doctors that I've got an extra heartbeat, but I wouldn't have known that if I hadn't have had that telehealth.
The nurses act as angels. You couldn't pay them enough money. They are an integral part of this system, and without it, and all the other stuff, I just wonder what we did before.
When you're not well, your brain doesn't work the same, so you get a bit confused, but they understand all that. It's a lovely feeling to know that there's somebody down at the other end of the phone that cares.
Great. So that was Lily's story, and you can see Liverpool Community Health are sort of highlighted there. And it's worth saying that the My Programme Board was comprised of a number of stakeholders in Liverpool. Our Liverpool Community Health, our community nursing provider, the CCG, informatics, major companies like Philips and Tunstall were also involved, charitable bodies on disability living, assisted living expertise, and some external scrutiny as well. So I guess the question is, so what? Which is always my question, in truth, for those of you who know me. So I think this is so what. This is really key. So patient-reported outcomes. This is interesting. The telehealth users, they thought that they were using their healthcare providers less. They thought they were having less GP visits, community matrons. So that was their implicit feeling. People reported improved self-care, and they thought, again, they were using health services less overall. 70% reported behaviour change. Now, this is fantastic. 91% of our telehealth cohort felt more in control, gained confidence. Now, I think this is absolutely vital because when we get to talk about outcomes, we do talk about hospital utilisation and we talk about healthcare costs, but we can't get away from our patients. And this is where you see the real benefit here. And I believe, personal view, that this is why we get the benefit, because people are more confident, because they feel more in control. So looking at outcomes, there is, however, a bit of a fly in the ointment in terms of anything like this, and Case will probably tell you a bit more about it, little bit on regression to the mean. So this is the statistical problem of, if you take a large group of people who have had something happen to them in the last 12 months, let's say hospital admissions, 2 or 3 hospital admissions in the last 12 months, and you monitor 100 of those people without doing anything whatsoever, they will have less hospital admissions the next year just because of the statistics. So in order to demonstrate benefit, you need to do better than regression to the mean. And that is one of the big challenges. So in Liverpool, we've taken advantage of people with large brains, and we've done an anonymous case-matched study. And I'm not going to tell you anything about that. I will, however, tell you our results. So we can now demonstrate, over and above regression to the mean, reductions in costs from 22 to 32% and reductions in hospital admissions across the same amount of percentage points. And the second point there is, it says across an average risk of 25%. So what does that mean? So for those of you using risk stratification software, we can look ahead and we can say the risk of any given cohort in our population of being admitted to hospital in the next 12 months is 90% or 80% or 7%. So we're showing benefit at levels above 25% risk, which I think is phenomenally exciting and really means that we can cover many thousands of people with this technology and get benefit. So without further ado, I will hand over to Case, who hopefully will take you through some of the very technical details behind that. So thanks very much.
Okay, thank you very much, Maurice. My name is Kees van Berkel, I work for Philips, and I've been working very closely in Liverpool for the last 4 or 5 years as part of my program. And Liverpool is a great place for many reasons. It's great. It has great people. It's got a great system, but it also has great data. And we've been able to use the data available in Liverpool to demonstrate that this service is effective. So Liverpool runs a risk calculation process, which is based on 36 parameters from inpatient, outpatient, and GP data. And examples of those parameters are deprivation, circulatory diagnosis, the number of emergency admissions in the last 12 months before the calculations, and other parameters. And the great thing about Liverpool is not only is that calculation done once, it's done every month. So we can see what the risk is of somebody now and what is it next month or what was it a year ago. So we can track the risk history of people over those 3 years, and we can track the history of those different parameters over the 3 years. So we can see, do their emergency admissions go up or down? So we can see who improves, who deteriorates. So that gives us an insight into the regression to the mean factor that Maurice mentioned just now. So this is a distribution of the risk profile of Liverpool, and so in different risk bands, so 0 to 10%, 0 to 20%, etc., etc. And I draw your attention to the logarithmic scale on the y-axis of this. So it's although the bars look similar size, they are certainly not. Almost everybody in Liverpool is in the 0 to 10% risk bracket. Well, thank goodness for that, because if they weren't, the CCG would have a massive problem with all those people. So on average, the risk of everybody in this room, of the whole population for an emergency admission, is about 6%. That's the prevalence of an emergency admission. So most people are in that 0 to 10% risk bracket, and then the next bracket has 5 to 10 times less people, and then by the time you get to the top risk brackets, there are very few people here, 440 people, 340 people in the very top risk brackets. So that's for all the people in Liverpool. What does the risk profile look like of the people that end up on telehealth that Maurice has just been talking about? So this is the profile of people that have been on telehealth. Now we are on a linear y-axis, so the size of the different bars is comparable. And as you can see, the single largest group is actually people in the risk bracket 10 to 20%. So that's kind of surprising initially when we looked at this, that there's such a large proportion of people in a relatively low risk bracket that have been recruited onto the service. But this helps us explain why perhaps we didn't understand the risk calculation sufficiently at the beginning of the program. And indeed, one of our first attempts that Maurice didn't mention, that we tried to use risk as part of the selection criteria in Liverpool, and that didn't really work. And this graph kind of tells you why it didn't work. When you try to find people and you use other criteria, such as the clinical criteria that Maurice showed, you end up with a profile that's very, very broad. The line in the center here is the ratio between the number of people in that risk bracket that we recruited divided by the number of people in Liverpool in that risk bracket altogether. So the line is the ratio between the bars on this graph and the bars on that graph. And as you can see, that the ratio of people, or the percentage of people that are in the lower risk bracket as a percentage of all the people in that group is very, very low. So as a statistician, you'd say risk is quite a good predictor of being on telehealth service. But as a clinician, you'd say it's not a good decider of whether somebody should be on telehealth. And that's one of the lessons that we learned, that actually you have to be clever. You can use risk as a decider or as one of the determinants of whether you want to select somebody for service. It can't be, however, the only deciding factor. So this shows you how we've used data in Liverpool to analyze the population and learn a little bit more about our own service. Another way in which we learn more about our own service is through operational data, and this shows you some of that operational data. On average, people are on service for about 3 months, and on average, the graph here on the left-hand side shows you how compliant people are with the service. So 0% is for those people that never do their vitals or answer any surveys, and 100% here is for people who do it every day. And on average, people are 60% compliant. So you can think, is that good? Is that bad? Do we want to improve that? Don't we want to improve that? The same thing for the number of tasks. So we can track whether how many tasks do people generate, and how does that impact on the workload in the service hub. So on to the evidence, the objective evidence for telehealth. Maurice has already talked about the subjective, the patient-reported evidence. So the number of patients, we've taken a slice of patients in about sort of the end of 2015, and we had then 1,800 patients, and the characteristics of those patients in terms of age, the gender ratio, the diseases is illustrated here. So, and the average risk is 26%, and the number of emergency admissions they had on average was about half an emergency admissions. And what we then did with the data available in Liverpool, we then, for every person on telehealth, we then found 3 people in the data set, in the anonymized data set, that had the same characteristics. So the same age, the same disease, the same risk, the same number of emergency admission, and even also, actually very important in Liverpool, the same deprivation score. So we matched people as closely as we could without knowing those people, because this was an anonymized data set that we were using. So the control group that we then, we then said we matched those people in time and on service. So we said, okay, well, we now pretend that these 3 people are going on service or not on service, and we track their history as we track the history of the patient that is on service. So this is the intervention group. That's about 5,000 people, and as you can see, they match that intervention group very, very closely. If this was an RCT, you'd say this is a pretty well matched control group. And of course, in some ways, of course, it's a designed match, because actually this is a retrospective match. So of course we have a very good match between the intervention and the control group. And the advantage we have here, though, is we don't just have an intervention group and a control group, but we have a link between every person in the intervention group and people in the control group. So we can subdivide the intervention group and look, okay, well, how does this subgroup, people over 25, people with a certain disease, people with a certain risk score, how do they fare in comparison to their control group? And this is an example of what we've done here. So if you look at all the people that have been on service for more than 6 months and have an average risk of more than 30% for an emergency admission in the next 12 months, and there's 120 or 119 people in the intervention group, their average risk was 44%, obviously bigger than 30, and the number of admissions they had in the 12 months before they started telehealth was about 1 admission. And then in the following 12 months after the start of the program, although they were not necessarily on the program for those entire 12 months, but in those 12 months after the start of the program, they had on average a third of an admission less. And you can then compare that with people that matched them in the control group. And there's 284 people in there. Their average risk is the same. They have the same number of emergency admissions before the service started for them, and they did not reduce their admission. So there's a difference, and the difference in this case is statistically significant. So we can do this sort of group by group tracking, and does this work for this group or a different group? And so this is a graph of that sort of doing this exercise repeatedly. So this is doing the same exercise, but then for different risk cutoffs. The blue line is for the control group, and the red line is for the intervention group. So you can see that as you go up the pyramid and you take people at higher risk, even the control group reduces their admissions. And that's the regression to the mean that Morris was talking about earlier on. But the red line for the intervention group shows a stronger reduction. So we say that the difference between the blue line and the red line is due to the intervention. And we can talk about that. We can discuss whether that's true and whether there may be other confounding factors. But at least it creates a more scientific discussion around the efficacy of telehealth than has been taking place before. Because what it does, it allows us to say not only does it work globally for everybody, but we can also begin to see, does it work, for whom does it work, and beyond that even, why does it work? So one of the conclusions that we found, Morris has already said, a reduction of 22 to 32%. We generally find that the effect is more immediate and quicker near the top of the pyramid. In the bottom of the pyramid, we see a slower the effect is smaller, and therefore we're not quite getting the statistical significance that we would like. And we find that the longer that people are on service, the bigger the effect is. So in the last few minutes that I've got, I'm just going to talk to you a little bit about how we now use these sorts of outcomes elsewhere to drive program design. As I've said, we've learned a lot about how risk works and how it doesn't work. So what we've done in designing our Kaiser Permanente pyramid, we've begun to define our cohorts not just by risk, as the traditional Kaiser Permanente pyramid does, but also by age and disease. So we begin to define different cohorts, and cohort 1 is everybody with a risk above 25%, because those are the people for which we have a statistically evidenced outcome. But we also say those people have to be above age 55 and with a certain disease profile, because we know that if we don't do that, we also end up picking up a lot of other people that should not really be in the telehealth group. And we do the same thing for cohort 2 and cohort 3. And what's happening in a place like Lancashire, where we're involved in the NHS testbed, there we begin to put together a program, an intervention program for each cohort. So not just the telehealth program, but actually work with other parties, SMEs, charities. So take the lessons that we've learned in Liverpool about working with competitors and working with charities and council organizations, and begin to put together a portfolio of services so that we can address the question of one size doesn't fit all. You offer choice to people. If you want to test whether patient engagement is real, you want to ask, does the patient have a choice? Because if the patient doesn't have a choice, there isn't really a patient-centered service, is there really? And we are very committed to making patient choice real, because we think that's the way to deliver patient centricity. And then in cohort 2 and in cohort 3, we deliver different service packages. And we think that's the way forward for this area, a supermarket approach, if you like. Nobody likes to go shopping in a shop that only sells one product, right? And even if you wanted bananas, you wouldn't go to a shop that only sells bananas. You'd go to a shop that sells lots of different things. And why are we not doing that in supported self-care? So we need to offer choice, and we need to offer a spectrum of programs for people to choose from. So that's my conclusions. I think Liverpool has been a great place for us. We've done set up the primary care-led service, and that allows us to develop a model of population management across diseases and services. So thank you very much.